And I will speak probably a bit from my experiences over the years, and it's very different in different places, training and supervision. Um, I was doing a supervision session this week with people in South Sudan, for example, and I asked them what sort of clinical cases do they see in their clinic? And they said, and this was really chilling, they said rape. So for South Sudan, the teaching, the training, the supervision would have to be geared around that. And also really thinking about the care, the self-care of those people dealing with such difficult cases every day. And so now I'm not going to ask which of you are involved in training and teaching, because I think all of you will be to some extent. For me, I always think back on my medical school. I always think back on the lectures that I attended and how much I slept during lectures at medical school. And the aim of mhGAP, I think one of the big aims in training and teaching is to make it interesting and stimulating. And then it's much more enjoyable. So I know that the traditional model of training is the formal lecture, and mhGAP has that, but it's also got a lot more other activities, and it's a lot more interactive. It's adult learning. If you attend a lecture, you remember just a small proportion of what you do, what you see. If you have some more active learning methods, then you can learn a lot more. And I think the ultimate way of teaching is to have some sort of exercises, and then the participant has to lead and do teaching, which is exactly what I see in this course. And I think some of you I'll be seeing tomorrow for exactly that purpose. So I'd like you, firstly now, this probably will work in the chat. If you write in the chat different two types of teaching style that you use. So if you write the chat. Okay, so thank you. And one thing I will say to you is, now that we've moved online for a lot of our training and teaching, this is teaching technique, using the chat room to the full extent. And this is an exercise in brainstorming. And so as I suspected, I think you all know lots of different teaching techniques: small group discussions, case-based learning, reflective time, facilitative and authoritative is the more traditional model, and there's a place for that because you can get a lot covered for a lot of people. And for undergraduate, when you have a lot of students, that might be ideal. But I think now in colleges, it's going to be a mixture of things. That's just going to be one part of it. Role plays and lectures. Now, the unit of mhGAP teaching is role play. And that can be a challenge for people who are not used to it. We'll come back to that. Large group discussions, Absolutely. And that's a place where you can have brainstorming exercises as well, small group discussions, case studies, visualization imagery for sensitive issues. Maybe we'll come back to that. Case discussions, interactional, absolutely. Student-led presentation and hands-on interviews. Yeah, and hands-on interviews, I think one of the things I've been involved with, which goes between training and supervision, has been on-the-job training, where I was, for example, I think over about 6 months, would go to a primary care center and I would sit with a doctor for their clinic. And I would not get involved directly, but I would look at what they were doing and try and in between patients or afterwards, try and help them improve their professional practice. Facilitator-driven teaching, yeah. So I think you have covered an awful lot. I think the visualization imagery, I'd also think of the videos. And I think you've maybe heard of the mhGAP videos that are in Arabic, but I know that we were trying to set up to make different ones in Bangladesh. I'm working now in Fiji, where they've made quite a lot of videos using local people. So maybe Pakistan needs to do their Urdu videos for local circumstances. So I'd like to talk. So in mhGAP, the way I tend to work, and I think this, a lot of people might agree with me, is to start off with a mini lecture. And then I would say having 2 or 3 different teaching methods. For me, what I do when I'm doing a lecture, and I will have the PowerPoint, but probably every second slide, I will ask someone a question. I will bring it to the group. So there's always something interactive, because for me, I find PowerPoints very hard to look at. I find they're quite tiring. So every 2 or 3, bring people in. When you've got a live group, then you do that. That's easy enough. Ask people questions, but you can also online, it's the same. Now, you may get in a group, some people are more confident at speaking, and some people are less confident. You try and get over that by introductions, and so that making everyone feel comfortable at the beginning, and having the ground rules so that people know that it's going to be non-judgmental. It's principles of adult learning, so there's no bad questions. So in that way, but sometimes, and I'm sure you will have seen trainings, that there are some people who don't like to be so vocal. And it's a challenge how you get those people who are more shy to speak, to be part of it. And people will have different ways of doing role playing. I'm probably so used to it that I kind of think everyone is well prepared for it. And it's not always the case. I know, working with Dr. Asma here in a number of different places, how we've worked is I'll say to Asma, okay, you're the doctor, I'm going to be a depressed person, and we'll just go with it. But for often you do need to have preparation and to have things well prepared, have some ideas of the script, etc. What I will do now with the video or with the role plays is probably make it match the videos. And then the things with role play that I will always insist on is having the mhGAP open in front of me, so that I will look at, and then what I'll do is I'll have a look at everyone either in real life or on the screen if they all have their mhGAPs open in front of them. So I can put mine up in front of me. Can you all put your mhGAPs up in front of you readily? That's another teaching exercise. Because I'll want to know that you've got that mhGAP and that it's well thumbed through. By the end of the training, people will have gone through every page. They'll be able to know that PTSD is purple color, epilepsy is blue, suicide is red, that they will have that intimate knowledge of the book. So, but in the role plays, it might take some practice for people. And I've always kind of will go to the group in the beginning and say that we will be doing role play because this is the unit of mhGAP training. But you can start off with maybe small groups, real life 2 or 3 people. You can break Zoom into small rooms, and then you can, people will get more confidence with that. So other tools, so the role play, yeah, my general plan when I'm doing a training is I'll have a mini lecture, probably 15, 20 minutes, with it being quite interactive, and then followed up by at least 1 or 2 role plays, small group discussion, and case-based discussion. How I start every training is I'll ask people, please tell me a type of case that you have seen. So when I was in Pakistan, people were telling me cases like conversion disorder, hysteria cases, because I don't see those so much in UK. And if that's what people are telling you about, it might be that it's something that's more on their mind. As a psychiatrist, there's always a tendency to kind of talk about things I'm interested in. I work in an inpatient unit, so I see psychosis all the time. But for primary care settings, what is common is depression, anxiety, stress conditions, even psychosis. Is maybe someone in primary care might see psychosis case once a week, something like that. So different in different places. Now, eating disorders. In my country, we see a lot of eating disorders. In Pakistan, there are eating disorders for sure, but it's not quite so common. So you would need to focus on what people see in primary care. And I think this is another thing. As psychiatrists and psychologists, we learn from our participants, and we learn what the world is of primary care, or what the participants' world is. So the participants are the experts on their local area. And a lot of mhGAP and management is about utilizing local resources. So often I'll get in trainings, I'll get asked something, and I will always kind of turn it back and say, well, what do you do here? What's your practice? Whether that's Peshawar or Karachi or Islamabad or Lahore. Although I think everyone here is from Islamabad. So other things, other teaching things I think you haven't mentioned are quizzes. There's pre and post test can be very helpful because that will give you some data. That will give you data for what often you need to do is a report. If your project is funded, then you're going to be asked to do a report. And if you have some figures, it's really helpful. And that's other teaching things are feedback at the end. So you'll be able to improve the next training. And HIG training, I've done 40 trainings roughly, and I'm still learning and change every time based on the last training. The first HIG training I did was in Iraq, and that was at the time of the Yazidi expulsion, and the Yazidi people were in a terrible way in Iraq. We learned a lot from that training, and that went into actually changing the final production of the mhGAP. So you learn a lot, quizzes throughout, question and answers, talking about cases they see. I'm going to just finish there in just a moment. I would like to invite any questions from anyone about this. Or Dr. Asma, if you have any comments.
Thanks, Peter. I think you've covered all the teaching methods.
And I think this is people's bread and butter. So I think I would learn from you guys.
So I've given them a challenge that in the next 2 days, we want to see as many teaching methods as possible. So hopefully you and I will have some excitement here.
Yeah, and we'll see something new. We'll see new ones. Now I'm going to move to the next topic, which is on supervision. And I've got my big challenge, which is trying to get a PowerPoint up and share it, which I can't tell you how stressed that makes me. But for me, I'm always...
Would you like me to do it?
Sorry?
Would you like me to put it up?
I think, no, because I haven't sent it to you yet. This is one that I think I'll be able to in a second. But Zaidan, I think you had a question.
Just a quick question, Peter. This recent experience of moving to online teaching, can you share some experiences of interacting with people in person versus online, especially when you're training them?
Well, the first thing that's amazing, wherever you are, is the reluctance of people to put on their cameras. It's amazing. I can see everyone's camera is open here. Now, that never happens in training. However much you'll tell people, I know that's for some people that have very good reasons. I know my reasons when I don't have my camera on is because I'm doing other things and I'm not concentrating. And I do wonder if that might be the case. But I've got some tips on interactivity in these slides on supervision, but I would say I've done a lot of online work. What I will do to start off with is go through introduction very carefully. I like to see everyone's names. I like to see their video open. And then I will, during the session, use people's names all the time. And so I will ask people questions and I'll go from one person to another. If someone doesn't know something, that's fine. Go to the next person. Using the chat room is it's a really useful tool. Breaking into small rooms is quite good, although overall I think doing it online makes a 60-minute teaching. I think it probably needs to be 90 minutes because it takes just that little bit longer. But let's come back to that when I've talked a bit about supervision as well, if that's okay. And I'm going to see if I can share my slides now. And I'm going to talk now about Wow, it's working. Oh no, I don't know if it's working. Can you see my screen? It says supportive supervision.
Yes, we can.
Wow, I'm impressed. Okay, so one of the engines of mhGAP to keep it going is supervision. We know that around the world, when mhGAP doesn't work, supervision is one of the common reasons why it doesn't work. Supervision is the engine that keeps it going. I know myself, I've done trainings in many places. Supervision wasn't in place and it didn't really work. And sometimes it can take a while. So for example, like with Dr. Asma, we were in Sudan doing an mhGAP training, and I had done an mhGAP training, I think about almost 10 years before that, or 9 years. Sometimes it takes a little bit of time, and then it does need the strong leadership to keep it going and to make it work. Other places I've done mhGAP training where it was kind of like an introduction and a taster in some very challenging countries, because we know it would take a lot of, there was a lot of kind of politics, and so it sometimes can take a while. So I think to be aware not to be too disheartened if it doesn't happen straight away. But in your mhGAP plan, you need to have supervision built in from the beginning, really, is my suggestion. This session is about supportive supervision, which is the term that we use. Training in mhGAP is the first part. Supervision is the second part. Now, when I'm doing, when we're doing training or setting up an mhGAP program, I will make it that people don't get their certificates until they have had maybe 3 supervision sessions. So just to make sure that the supervision happens. And ideally, this should be within a month after an mhGAP training. And the ideal is sort of once a month for maybe 1 hour protected time. Now, for psychologists and psychologists, I think we have, for many of us, we have supervision in our framework for ourselves, or we supervise other people. Although as a consultant psychiatrist myself, I don't get any supervision. And that's probably a strange thing, because we probably all could benefit from supervision. So as I was mentioning earlier, I think probably the first sorts of times I was doing supervision, I didn't realize I was doing supervision. I was working in Darfur, and I was supervising refugee workers. This wasn't mhGAP, this was before mhGAP. So getting those people to help them have the confidence in managing local cases. And I really learned so much from those refugee workers. Next, it was in Haiti during the time of the earthquake in 2010. And there I was working in primary care settings. The supervision was very intense. It was weekly, sitting in a clinic, training everyone in that primary care center, and also supervising the doctors. And there were some horrible things I saw. So, and they were actually in some ways great learning experiences. There was one time a lady came into the clinic. She said she had just been raped. And the doctor said to her, "What's your HIV status?" So after the session, I was able to role play that with the person and say how they could have done that better in a more sensitive, empathic way. And they learned from that. they learned to be empathic. And so just some other examples, like this is face-to-face supervision. This was South Sudan. And there's nothing like face-to-face supervision and going through supervision. You can see there's a pair of people there and myself. It's very nice to go through it like that. These are some other examples of supervision. This is like moving to the online world. So this was a supervision I did recently with the refugee camp in Kenya. And to my astonishment, I thought it was going to be 1 or 2 people, but it was a whole classroom of people. And it was quite daunting because I must have been on a huge screen in front of them. And what I did there was I went through introductions and got all their names. And then I directed my questions to all of their names. I tried not to exclude anyone. And then we went through the topics and had some supervision in this way. We did role plays. And to me, I was astonished that you can do it in this big group on a distance. But we did role plays. We did some small group discussions. We did true or false questions. We talked about local cases. And yeah, I was quite proud of it because I didn't think it would work, but it did work like that. So Northeast Syria, I've been working with more recently. And this is Kobane, which was under IS for quite a few years. And these were the psychiatrists there. And this was with translator. And of course, you can see the challenges of doing supervision like this because they're wearing masks. They can't stay too close to the screen because they're all wearing masks because of COVID. And so trying to hear them was quite difficult. And then the translation. But it worked. And there we talked through cases that they brought up. They wanted to talk about epilepsy because they see a lot of epilepsy. They see a lot of stress conditions because of the war and conflict. So some points I would say about supervision is that online supervision, I think, can be as good as face-to-face. And there are probably some advantages as well and disadvantages. You need to have a strong administration. Some places are better than others. Like I'm doing some supervision in South Sudan and that works fine. But there's sometimes, well, think of another country where 3 times out of 4, there's internet problems or no one is turning up or there's confusion over times. So you need strong administration to make sure it happens. Strong internet, which is difficult. I'm not sure. I think Pakistan is quite lucky with its internet, I think. You need to have committed time. So if you're supervising primary care people, they need to be able to leave their clinic for an hour. Now, I think in Pakistan, if I can remember, in primary care, clinics are really long. You may get 60 people at a primary care clinic a day, leaves very little time per person. So you need to make sure they're able to be released from their job for the supervision and to make sure that they have the time to do it. It needs to be timetabled, needs to be, some people would say incentivized, but you can frame that as continuous professional development and a personal relationship. You need to make it interesting and relevant. And the elements that I would go through are clinical, so talking about cases, administrative, which could be about like how you do your recording of cases, so that at the end of the month, I'm able to look at how many MNS cases, mental health, neurological, or substance abuse cases that you're seeing. If I'm implementing mhGAP, I'd expect to see an increase of MNS conditions reflected in the diagnoses. And I want to look at the clinical records. So if it's online, they will need to you need to see how you can get those to you in a confidential way. Programmatic, that can be looking at things like, as the elements of the mhGAP program here, have you got a confidential space to see people? Have you got access to psychotropic medication? Are all the ingredients there for mhGAP to work? It also could be about local stigma and about what people think about mental health in the community, the challenges, etc. Challenges. So I think there's a challenge when you're doing supervision in that you may not see people actually in their clinic directly, because you might arrive when their clinic is finished or whatever, especially if you're doing online, but you can always do role play. You may miss out something. So for example, in physical examination, are people getting permission, asking for permission to do the examinations? Is there confidentiality? You want to check that the facility is suitable. I've been in some places where 2 clinics were happening in the same room, so there was no confidentiality. The challenge as well is keeping to mhGAP focus. So the mhGAP, and this is something that psychiatrists and psychologists, I think we can be to blame for, that we may not focus, we may deviate. We may talk about interesting cases we've seen, but we need to always come back to the world of primary care. And then looking at why we do supervision, it's about quality of patient care. It's about making sure that patients are at the center and their care is improved, and that the outcomes are better. So the challenges, internet, there may be some people that are interested and some aren't. And when you're doing trainings in mhGAP, you lose people along the way. Not everyone is going to be interested. And I can just think, well, it wasn't supervision, but it was training. I remember in Peshawar doing training on mhGAP in Peshawar. And I don't think any of you were there, but there was one family doctor, a lady doctor. And at the end, she was saying, I've learned a lot of things that I'm going to use in my practice. I've read some really, really useful tips. I knew she had made the most benefit out of the training, and she was going to use those things. So in supervision, she'd be someone I'd be very keen to support, because she would be a supervisor herself. And she would really be a great resource because she was so eager to learn. So I will stop sharing now. And perhaps Dr. Asma, can we do a quick role play?
Sure.
You will be you can be the mhGAP primary care doctor.
Okay.
And I'm your supervisor.
And are you doing good way and bad way both, or
We'll
are
see.
you doing?
We'll see. And just the rest of you just can observe and comment. Okay. For you, when you're doing exercises like this, you might need to prepare yourselves a bit, because myself and Dr. Asma, we've done this a lot, so we can go right into it, I think. So Good morning, Dr. Asma.
Good morning.
Thank you for letting me come to your clinic. I've got very little time though. I've seen your clinic. It's really not very good, is it?
It's okay.
It's not okay. I saw you missed a case of depression, you missed a case of anxiety. I didn't see the mhGAP anywhere. This was not great. I don't know if you were just asleep during the training.
Oh, I see.
This was very disappointing. I don't think this was good at all. So I don't know how we're going to do mhGAP. You clearly have no interest.
Yes, maybe I can't do it.
That's probably true. So I'll speak to the director of the practice, and I'll leave now. Right. Thanks, Dr. Asma. So a little bit of a caricature, but what did you think of that supervision? Dr. Israr.
Let me open my mic. Okay, it seemed overly critical to me. There wasn't any opportunity for the mhGAP healthcare provider to speak, and the supervisor was mainly giving critical comments. So I think overall it might have been the bad case presentation.
Yeah, I was clearly in a bad mood. But Asma, you were doing that as a role play, but as a role player, what did you feel in this exercise?
So I felt that you came in as somebody who knew much more than I did, who was there to judge me, who was very quick to conclude that this setup and I as a physician am unfit. And in some ways, whatever training I might have received prior to this, it was a waste of time, and investing in this trainee for supervising is a waste of time. You also looked kind of rushed. So it seemed as if you didn't have enough time. It also seemed as if you were not motivated to supervise. So those are some initial thoughts.
Yeah, thank you. So I'll just do it again with you, Dr. Asma, if that's okay.
Sure.
Good morning, Dr. Asma.
Good morning.
I'm Dr. Peter, and I'm here to talk to you, and we're going to have a supervision session. So, Dr. Asma, can I first check, have you any patients waiting for you, or you're free to speak at the moment?
Well, actually, I organized my clinic in a way that I have these 30 minutes to speak to you. So fortunately, there is nobody waiting to see me.
Great, great. And what I might do, Dr. Asma, if that's okay, is have a look at where you see patients a bit later, just to make sure that it's a suitable place. Now, Dr. Asma, I know you did the training on mhGAP-HIG, I think it was about a month ago.
That's right.
And it might be difficult to remember things. So one of the things we're doing here is just kind of a refresher and reminder of some of those things and help you put them into practice. So have you been able to use the mhGAP-HIG since that training?
So I must admit, Dr. Peter, that I have not been able to use it as often as I thought I would. Sometimes there are too many patients for me to see, and there is just no time.
Okay.
But I have been making sure that I at least refer to the guide once every day.
Okay, so that's really good that and it looks like the guide is there close by you. And I appreciate that it's quite difficult when you've got so many patients. What I hope, though, Dr. Asma, is that by using the guides, it might make the burden of your work a bit easier. So Dr. Asma, do you ever get patients who keep coming back to you again and again and again with no, for example, with medically unexplained complaints?
Yes, I have many patients. And in my training, in the training that we did a month back, I was told that I have to try and engage them better. And once or twice I have opened the guide also when the patient was here, but I am really afraid that the patients will think that I do not know enough, and they will lose faith in my skill if they keep seeing me looking at the guide.
Yeah, that's a real challenge. It's a real challenge. And I think what sometimes can happen is that those people who come back again and again can take up quite a bit of time. And one of the things with mhGAP is maybe being able to work with those people, and they may, if things go well, they may come back less and less, and you've got more freed up time. But this question of having the book in front of you and people saying, oh, you don't know what you're doing, you're looking at a book, is a real challenge. So something that I say sometimes is, I'd like to ask you some routine questions, or I might have the book in my eyesight, but I'm not looking as if I'm reading it, if you see what I mean. So there's different ways of getting around that, but I know it's a challenge, this thing of being able to use the mhGAP easily. So Dr. Asma, I'd like to make another appointment for a month's time, and the next time I come along, perhaps we can talk about any particular difficult cases and see how we could work with those so that if they're could free up your clinic a little bit.
Okay.
And is the director of the center, is he supportive to you?
He's okay.
Okay.
But I'm as I was talking to you, I was thinking that maybe I should, these patients who keep coming back again and again, maybe I can ask them to come at the end of my clinic when there isn't a long waiting list and I can spend more time on them. And if I do a few patients like that, maybe I could discuss their treatment with you on your next visit.
Absolutely, Dr. Asma. At the same time, Dr. Asma, I don't want you to lose out on your work-life balance. I don't want you to be staying late. I want you to be able to not to be working too late. The mhGAP is here to make your life easier, but I think that's a good idea. But don't work too much. Don't work too hard.
Okay.
So
Okay.
thank you, Dr. Asma. I'll make some notes of this, and the next time we'll talk about those things again. Thank you.
Thank you.
So Zahra, what did you think for that one?
I think there were a lot of good things. It was respectful. You checked if she was available. It was constructive. It focused on what allowed her the space to think of what her problems are. So instead of you pointing, if she was already pointing those out herself, you didn't need to sort of go about doing that. You were also checking for the environment, because we know that a doctor alone may not be responsible, may have a lot of other things happening, and to check on the environment. So you checked if she has that kind of support. And you also didn't want her to go beyond certain things so that she ends up being too stressed, and that's not sustainable. So a lot of things there.
And I think we all will have different ways of supervision as well, and different things that come up. But I think the principles are that we cover clinical areas, we cover administrative areas if we had the full 50, 60 minutes,